Thank you for joining me for our Fertility 101 webinar. I am Dr. Ilana Ressler, and I am a reproductive endocrinologist. Here's a little bit about myself. I have my degree from Duke and then Case Western Reserve. Then I did an OBGYN residency in Chicago, followed by a fellowship in reproductive endocrinology and infertility in Cincinnati. And I have been with Illume Fertility since 2017, and I'm really excited to be talking to you tonight about just Fertility 101, the basics of how fertility works and how we evaluate it and about how we treat it. So a little bit first about our practice. We have 5 different locations, 4 of which are in Connecticut, Norwalk, Stamford, Danbury, and Trumbull. And we have a New York office in Harrison and Westchester. We are 9 physicians, all board certified in reproductive endocrinology and infertility. We have an on-site surgical suite and IVF laboratory, as well as andrology laboratories in all of our 5 locations. We are an LGBTQ plus healthcare equality leader. We also have an amazing program called the Integrated Fertility and Wellness Program. So we offer not only the medical care needed for treating fertility, but also all the bonuses like nutritionists, acupuncturists, support groups, and so on. So you can learn more about us on our website, and happy to speak more, of course, offline. So in terms of what we offer, all of the fertility evaluations, we offer fertility preservation, whether that's in the form of egg, sperm, or embryo freezing. We offer treatments for ovulation induction, IUI, IVF, as well as third-party reproduction, including donor egg, donor sperm, and gestational carriers. As I mentioned, our IFW program really offers the holistic support as well, including the acupuncture, counseling, nutrition, and different support groups. Okay, perfect. So now let's get started and talk about Fertility 101. First, we're going to run through some myths and facts, maybe commonly misunderstood about fertility. So first myth, infertility is rare. It actually affects 1 in 6 people and is a lot more common than you may realize. Myth, infertility is a female issue. Nope, it affects men and women equally. Myth, it's easy to get pregnant. Actually, reproduction is a really inefficient process. If the definition of infertility is trying to conceive for 1 year before seeing a specialist. True in some cases. However, if someone is 35 or older, we do recommend coming to see us at that point after 6 months. So what is infertility? Well, it used to be defined just as trying to conceive without success after 1 year, but actually our professional society, the American Society for Reproductive Medicine, just recently changed that definition to include needing medical intervention in order to achieve a successful pregnancy, either as an individual or with a partner. So this is a really exciting new definition because it's really more inclusive of everyone, not only couples, heterosexual couples who have been trying to conceive on their own, but also single parents by choice, LGBTQ plus community, and those needing a donor. So what are the basic building blocks for becoming pregnant? Well, we need 3 things really. We need an egg, we need the sperm, and we need the uterus. These might be all within one couple, or we can use these parts from others, which is referred to as third-party reproduction when someone else is involved. So let's just go through and think about what are the basics in terms of the female anatomy, because this is really understanding female anatomy and how the menstrual cycle works really is like a springboard for everything we do. So anyone who sees me for an initial consultation, I go through this description because Again, everything we do in terms of treatment is really like a manipulation of what I'm about to explain now. So in terms of the basics of anatomy, vagina here, cervix, that's the entry into the uterus. So that's like where pap smear is taken. Uterus here, it's made largely of muscle. The lining of the uterus is called the endometrium. That's what builds each month and sheds with a period. These are the fallopian tubes and the ovaries. So inside of the ovaries, that's where the eggs are stored. They're microscopic, teeny tiny, we can't see them, but we know every month there's a group of them available for use. And all of these eggs are contained within the ovary. So I know there's a lot going on this graph here, but let me just break it down for you because again, this is like the basics of how the menstrual cycle works. So on the bottom here, you can see numbers that indicates the day of the cycle. So day 1 is the first day of flow, first day of a period. And we know, as I just said, that there's a group of eggs available at the start of each cycle. And those eggs are contained within the follicles, which all appear little at the start of the cycle. Then there are hormones that talk between two places in our brain. They talk down to the ovary, it feeds back, and that's what really carefully regulates the cycle. So in particular, there's this hormone called FSH, follicle stimulating hormone, and that sends the signal to these follicles. And again, there's a whole group of them available for use at the start. And the FSH gets one of these follicles, which becomes known as the dominant follicle, to develop. So in a typical 28-day cycle, by the way, normal range is anywhere from like 21 to 35 days. That's considered a normal interval from the start of one period to the start of the next. The follicles are all little at the beginning. Then the FSH hormone picks one and it grows bigger than the rest. Mid-cycle, then the brain sends another signal, the LH surge, which triggers the ovulation. So this growing follicle is making estrogen. After ovulation, this site in the ovary then becomes what's called the corpus luteum, and then progesterone is produced from that site. So let me see if I can go back. So once the egg ovulates, it leaves the ovary, it's swept into the tube. It's there for about 24 hours or so, but sperm lives longer in the reproductive tract. So it's better to err on the side of having intercourse before ovulation rather than after, because the sperm will hang around and wait for the egg's arrival. So with intercourse, sperm is left here. Some of it will make its way up through the uterus to the tube. So this is where the egg and the sperm will meet. Once they meet and fertilize, it becomes an embryo. Then it takes about 5 days for that embryo to travel into the uterus where it will implant and grow. If no pregnancy occurs, the body senses this about 2 weeks after ovulation. All the hormone levels will fall, the lining sheds, we start all over again. Okay, perfect. So in terms of the eggs, there are two main aspects that we consider: egg quality as well as quantity. We know, unfortunately, both of these decline as we get older. So in terms of quality, there really isn't a measurement of it. We can't do like a blood test or an ultrasound that will reflect the quality of the egg. However, it is very closely associated with age, and this starts to shift in our mid-30s. That's when statistically it starts to be noticeable that there's a change in terms of both egg quantity and quality. Quantity, though, is referred to as ovarian reserve, and we have 3 ways of assessing ovarian reserve. One is a hormone called anti-Mullerian hormone, or AMH. This is a hormone made by cells that surround the eggs. So the more eggs you have, the higher your AMH. That goes down as we get older. That does not fluctuate during a cycle, and we can draw it really at any time, and it will be reflective. The second blood test, though, is specific to the timing in the cycle and needs to be drawn around day 3. There's a little wiggle room. It can be days 2, 3, or 4 generally. Again, day 1 is the first day of bleeding. This hormone, as we saw earlier, let's see if I can go back. The FSH should be low at the start of a cycle. That's why we check it then. As the quantity of eggs goes down, the FSH will increase. It's the inverse relationship. So we're looking for a higher AMH and a lower FSH to reflect good ovarian reserve. The third measurement is a follicle count. So I'd like to think of the ovary kind of looking on ultrasound like a chocolate chip cookie. And all the little chips are the follicles, and each side of each of those little black circles is an egg. We can't see the eggs, but we can count the follicles, and that's the third measurement of the ovarian reserve. So we put the AMH, the FSH, and the follicle count together to really get the best sense of someone's ovarian reserve. And this doesn't tell us exactly how many are left or when they'll run out, but it gives us a sense, does someone have like a low, average, or high reserve? And this also, by the way, does not predict the ability to conceive, right? So what it's really telling us is how aggressive should we be with our treatments, how to dose medications, expectations of how someone might respond. That's the way in which these ovarian reserve markers are helpful. And remember, quality is more important than quantity. At a certain point, the egg quality becomes too poor to produce a healthy baby. So as I mentioned, in our mid-30s, that's when slowly it starts to shift in terms of quality. By the time we're in our 40s, most eggs are no longer healthy. And by the time we're in our mid to upper 40s, essentially there's no more healthy eggs. So we might still have periods until menopause. Average age is 51 in the US. But before this time, starting in our 40s, unfortunately, the quality is such that it no longer is able to produce a healthy baby. So for those in that situation, we do offer a donor egg program, which is a very highly successful way to conceive using the egg of a younger woman with very high quality eggs. Okay, so let's talk just about a few more basics about the ovarian reserve. So we actually had the most eggs before we were born. Like when we were in our mother's uterus, we had about 6 or 7 million eggs. By the time we're born, it's down to about 1 or 2 million. Puberty, it's about 500,000. And we run out when we go through menopause. So we lose up to about 1,000 eggs each cycle. So in terms of age, just to reiterate, age is one of the most important factors and one of the biggest predictors of success for fertility. So really, it's never too soon to be thinking about future fertility. And if someone isn't ready yet, then we can freeze eggs or freeze embryos, and that captures them at their younger age, and they don't continue to age once frozen as they would in the body. So again, mid-30s is when this starts to decline. And even before then, unfortunately, many women are found to have lower than expected ovarian reserve. So let's say someone comes in and we find that the ovarian reserve is lower than we were expecting, and they haven't started their family building yet, and their goal is to have maybe 3 children. We really want to think about making embryos and freezing them for future use, because unfortunately, as time goes by, this is only going to decline and get more difficult. So it's good to recognize this earlier rather than later. Okay, so there's more to it though than just the eggs, right? So including the fallopian tubes and the uterus, these are 2 other parts that we examine when we're doing this reproductive checkup at the start of an evaluation. So this image here is of a hysterosalpingogram, or HSG. This test is designed to check out the health of the fallopian tubes, because remember, the tubes play a critical role. That is the meeting place for the egg and the sperm. So if both tubes were blocked for some reason, the egg and the sperm would not be able to meet, and someone would need to do IVF in order for the eggs and the sperm to meet outside of the body, and then the embryo is placed into the uterus. So this test is done through an X-ray, like X-ray dye test, it's called. We have the ability to do this test. We do this testing in our office, so you don't have to go to like a separate radiology suite, but we do this every day. We're very good at doing it. It can be crampy, so we advise taking some ibuprofen about an hour before, because as the dye is going in, for whatever reason, the uterus doesn't like it and it can be crampy. It's a very quick test, but unfortunately can be a little bit uncomfortable. So essentially, we put a little catheter into the uterus. We put the dye inside, we see it filling into the uterus, And then we should see it filling into both tubes and spilling out of both ends, again, confirming they're both open and healthy. Sometimes we might see that a tube is dilated. This indicates there might be some sort of problem with the tube, like some sort of prior infection, or that it's diseased, or sometimes people might have an inflammatory condition like endometriosis, which might cause scarring and damage the tubes as well. So this is an important test to do, again, at the beginning before initiating treatment. So this test, it gives us a little bit of information about the uterine cavity. As you can see here, we can see this uterus has the normal shape, but it doesn't give us a lot of detail about the inside of the cavity. So we do a separate test. It's called a saline sonogram or sonohistogram. There are a few different names for it, but essentially what we do is, again, we put a little catheter inside of the uterus and we put a little saline in there because the walls of the uterus are normally touching. We can't see what's between them. So by putting a little saline in, that just helps expand the walls. And we do an ultrasound, transvaginal ultrasound at the same time, and we can see with 3D imaging, a really good look at the inside of this uterus to see if there's any, what we call like filling defects. So this is a very obvious filling defect here. We see this huge polyp in the middle of this uterine cavity. So as you can imagine, if someone has a polyp like this and an embryo lands on it, it won't implant and it won't be able to develop. So we do this test again at the start to evaluate, make sure there's no, often the polyps are more subtle than this, but we find these very commonly. If we find one, then the solution is to remove it. We do this separately through a procedure called hysteroscopy, which involves putting a little camera in the uterus and taking it out with instruments. And don't worry, you're under anesthesia for that procedure, so you don't feel anything. But the saline sonogram really isn't painful. It might feel like a little pressure, cramping, but it's not a painful procedure. So not only can it pick up things like this polyp here, but some women have fibroids, which are like benign growths of the muscle of the uterus. And if they're in the outer part, like in the muscle or towards the outside of the uterus, those typically don't affect fertility unless they are really large size. But even if it's a little one and it's hanging out in the cavity, it really can have an impact, and we would want to remove that as well. We can also pick up, some people are born with different shape uterine cavity, like a little extra tissue down the middle called a septum, or other variations called like a unicornuate or bicornuate. So we can pick up all of these different shapes and variations through this test. By the way, we update this test like every 6 months because the conditions can change, little polyps can come up. So if someone is in our practice and it's been 6 months since their last saline sonogram, we'll just repeat it to make sure that everything still looks good. Okay, so as we said, the men are the other half of the equation, right? So it's important also to evaluate the sperm health. The semen analysis is really the best way to do this. And we measure a few key parameters. So one is the concentration, how many million per milliliter, the motility, how many are moving well, like what percentage of the sample are moving well, and the morphology, how many appear normal in shape. So actually, most sperm are abnormally shaped. That's normal, so to speak. So we are looking for just more than 4% of the sperm to be normal. As you can see, this is a normal shaped sperm here. Most are abnormal. They can have defects with their head, the neck, or the tail. You can see this one even has 2 heads to it or 2 tails. So most are abnormal in shape. And that goes back to the inefficiency, right, of reproduction, that if you think about it, it takes millions and millions of sperm. Like we want to see 15 million or more per milliliter to have a normal sample. It takes millions of sperm to fertilize one egg, and most of the time that doesn't even happen. So if we see that the parameters are all normal, great. We don't really have to do anything further. If we see that it's abnormal, we often like to repeat it because we don't know, was this like a good day, a bad day? We want a little bit more of a sense of an average. So we would repeat the semen analysis. If there are persistent abnormalities, then we would want to investigate that further. And we would work with a reproductive urologist who we would refer you to help further with that investigation. Different causes could be of abnormalities. It could be like a genetic cause, it could be anatomic, it could be hormonal. So they will further investigate and determine what the cause is and if there's any treatment to improve it. But even if it remains abnormal, we do have successful treatments that can overcome most of these issues. So just to recap, we've kind of gone through the different aspects of anatomy, and those are really the underlying causes of infertility, but it can relate to ovulation dysfunction. So going back to that regulation of the menstrual cycle, if there's any like hormonal imbalance that could cause irregular cycles, the most common cause is PCOS. That's a really common cause of infertility, and PCOS affects up to about 15% of women. It could be due to low ovarian reserve or poor egg quality or age, in other words. It could be due to endometriosis. There could be an issue with the fallopian tubes, with the uterus, or sometimes all the tests come out normal. And I like to think about it like fertility is a really complex process, and we have like limited ways of evaluating it, right? So with these tests, sometimes we can identify the cause of the issue. Sometimes we can't because we just might not have the right test to detect it. It doesn't mean there's not an underlying issue, but sometimes as we're going forward with the treatments, we even can understand more about what the underlying issues are, especially with IVF when we're actually looking at the eggs and the sperm and seeing how they interact. Sometimes we get more information about that. There can be other causes as well, what's referred to as social infertility. So those who might need an outside source of egg or sperm. Also, lifestyle factors can affect fertility. So it's important to, lead a healthy lifestyle to help the success of the fertility treatments as well. So what are the fertility treatment options? Well, one of the first steps we often start with is something called ovulation induction. That's when we like gently stimulate the ovaries so that not only one egg will develop in a cycle, but maybe two or three. We often do this with an oral medication like Clomid or Letrozole. We track the development of the follicles after someone takes the medication, and then we help time ovulation with another medication. And then that is often combined with both timed intercourse as well as intrauterine insemination. IVF is another option, sperm and egg freezing, and donor conception, and or with gestational surrogacy. So we're going to go a little bit more into detail with these. So in regard to egg freezing, this is really useful for those who aren't ready to conceive yet, but want to in the future and know the effect of age on their fertility and want to take that next step in helping to preserve it. So really the ideal time to freeze eggs is the age of like 30 to 35 before those effects start to take place in terms of the egg quantity and quality. It doesn't mean you can't do it beyond that, but that really is kind of the ideal window between 30 and 35 or even younger. So a woman will take hormones to help stimulate the ovaries to make many eggs develop. It's that same hormone, the FSH, that we naturally make every month, but it's just in much higher doses that we give it. We then take the eggs out through a procedure called an egg retrieval. This is really a minimally invasive procedure where we place a needle into the ovary, specifically into the follicles, and we drain all of the fluid in the follicle, and along with that comes the egg. Then the eggs are frozen using a technique called vitrification, and that, again, freezes them in time and preserves their the fertility really indefinitely. There's no like expiration or shelf life by which the eggs need to be used. And they are stored again until ready for use. So let's say someone freezes their eggs, let's say when they're like 34, and then 2 years later, they're ready to start their own family. I would say go for it, try on your own. We're not going to go right away to those frozen eggs. Those eggs are meant for like kind of last resort. If someone isn't able to conceive with their own eggs, we have those so they can turn to their own younger eggs before turning to someone else's or donor egg IVF. When we're ready to use them, we would thaw them, put them together with the sperm to fertilize them, and then grow them into embryos, at which point they can be frozen again as embryos, and one would be selected to transfer back into the uterus. There's a really high rate of attrition as we're going through this process in terms of the embryo creation. So studies show it's recommended to freeze like 12 to 15 eggs for any one future live birth. Now, in terms of IUI, intrauterine insemination, I mentioned earlier the ovulation induction, where we like track the growth of the follicles, we time the ovulation. And then, in addition to intercourse, where the sperm is left vaginally, we place it in the uterus at the right time. So the sperm is collected, it's washed, it's concentrated, so the best ones are available. It's placed in a little syringe. Attached to that syringe is a catheter, and then the catheter is just placed in the uterus, the sample left there. And we ask patients to rest for about 5 minutes after that's completed. It's not painful. It's done in the regular exam room, and then you can be on your way, regular activities for the rest of the day. It is a lower cost option than IVF. It's also less successful. So in terms of success rates, in sort of a gold standard scenario, when a woman is under 35, good uterus, good tubes, good sperm, it works up to about 20% per cycle. So we know it often is going to take more than one attempt, but studies show that cumulative success tends to peak and plateau around this 3-cycle point. So if someone is not successful after about 3 IUI cycles, we suggest moving on to IVF as the next step. This is going to be much more successful in that same sort of scenario that I just described. It's going to be more like 60 to 70% chance of success per transfer. It is more complex. It does involve, as I just described earlier with the egg freezing, stimulating the ovaries to get many follicles to grow. We then take them out of the body through the egg retrieval. We put them together with the sperm in the lab, grow the embryos until it gets to a certain stage called blastocyst. And again, that's when it can be transferred or frozen. This is more expensive than an IUI type of cycle. And this might be actually the first line treatment for those who have like a severe issue with the sperm, for those who have blocked fallopian tubes on both sides, or as I mentioned, after failing multiple IUI attempts. Some people choose to go directly to it because it's just more efficient and more successful as well. And donor conception and surrogacy. So what is this, and who might be interested in the use of this? So in terms of donor conception, if we have a same-sex female couple, we need the source of the sperm from a sperm donor, or same-sex male couple, we need the egg from a donor egg, and we would need a uterus in the form of a gestational carrier as well. So there are all different ways to build families, and each couple is really an individual situation. So while we, always like to compare ourselves to our friends and how it worked for them, just keep in mind that every situation is unique, and we're really going to see what would work best for you in your situation. Considerations for this: it's usually not covered by insurance and can be a high out-of-pocket cost, although fortunately things are improving in this regard as well. So that is a summary, brief summary of several different options of different treatments, and the way we would decide what treatment would be, again, to gather all that information through the reproductive checkup to start with, and then we would discuss the results with you and come up with each individual plan. So in terms of next steps, if you're interested in scheduling a consult, you can scan this QR code, more information about our team, and we have a Fertility 101 guide that you can access here. So I'd like to thank you for attending this webinar. You can see here all of our different locations or how to contact us. Let me see if you have any questions, there should be a Q&A. Let me just see if we can see this. Okay. How long does the fertility test process take? So great question. It usually takes about, I think of it like one cycle, right? So in terms of the female testing, we start everything with a period. So when I go through all of this at an initial consult, I always say, you don't have to remember all the details or the timing of when we do what. You'll just tell us when you start your next period. We do the day 3 testing around day 3. We do the HSG and saline sonogram like days 5 through 9 of the cycle. And then the semen analysis can obviously be done at any time. I didn't mention, but I would like to, that we also recommend a test called genetic carrier screening. This looks at commonly inherited genetic diseases, and we recommend doing this prior to initiating any treatment. That tends to take the longest to get the results, up to like maybe 3 to 4 weeks. So that is kind of everything else is pretty much like instant feedback that we'll give you right away. Once that testing is all done, we would meet back with you to review all the results in detail, even though, again, you'll be getting it kind of as you're going along, and then we'll decide the next step. So it takes about 1 month roughly to do the diagnostic testing if all done in one cycle. Okay, next question. How long does it typically take from start to finish for IVF? So again, I think of this, all of the different treatment cycles are kind of like a manipulation of the natural cycle. So in terms of an IVF cycle, if we think of it kind of in 2 parts, one is like the embryo creation and the other part is the transfer, right? So they can be separated into 2 separate cycles. We often do that rather than having it all in one cycle. A very common reason we do this is because we can test the embryos to see if they're genetically healthy. And we need a little bit of time to get those results back. So we would freeze the embryos, await those results, and then prepare for a transfer in a separate cycle. So if you think of the timeline for an IVF cycle, like the stimulation part, the timeline that a woman is taking the injections and coming in for ultrasounds and blood work to do the monitoring, I think of as roughly 2 weeks, but it's actually less than that. Usually on average, 10 days of taking the medications, and then you have a 2-day heads up before the retrieval. So think of it again, roughly 2 weeks of taking the medications, coming in for ultrasound and blood work. Then the eggs come out with the egg retrieval. Then it's another week for the embryos to grow, but you aren't coming in at any point during that. We're just giving you updates periodically with the development. Then after they're frozen, if we're doing the genetic testing, it takes another 2 weeks to get those results back. Once we feel comfortable with the number of embryos that we have to do a transfer, and we're focusing on the transfer cycle, from the start of that treatment cycle to the time of a transfer, roughly about 3 weeks. And then about 9 days later is the test that will indicate if you're pregnant. Okay. Is there an age cutoff for embryo freezing if you have no fertility issues aside from the age factor? So I'm not sure I fully understand, but in terms of like recommended age to freeze eggs or embryos, ideally, again, 30 to 35, but no, we don't say, okay, you're above 35, we cannot, freeze your eggs or embryos. We want you, though, to have appropriate expectations, right? So if you're 40, we will talk about what are success rates for IVF for 40-year-olds, and that's what you might be able to expect later on when you transfer an embryo that was frozen from an egg when you were 40. So we don't have like a cutoff per se. Of course, there are extremes, right? When we get to be like perimenopausal or menopausal, or even once we get to our mid 40s, right? That's when the quality is going to become a big factor. And so it's a lot less likely to be successful. But we don't have, we won't say if someone's above 35 or above 38 or so on that you can't freeze eggs or embryos. Okay, all great questions. Anyone else have any for tonight? Okay, well, thank you all for joining. It was great, speaking to you, and I look forward to hopefully meeting you in person sometime soon. Take care.